Good morning, everyone. I get the pleasure of kicking the family session off, so it's my pleasure to be here, and I want to thank the organizers for inviting me, especially all the members of the HCU community and HCU Network America. Let me see if I can get this rolling. There we go. So my topic is, what is homocystinuria? It's a broad topic, and we have a little bit of time to walk through this. Slides can get a little complicated, and unfortunately I don't have a great pointer, but hopefully you'll bear with me through some of the biochemistry, and we'll make this topic a little bit more understandable. So my disclosure is that I am currently a clinical investigator, consultant, and a speaker for Travere Therapeutics, who are the developers of pegtibatinase, which you'll hear probably quite a bit about this weekend. And the objectives today is to define homocystinuria, review the metabolic pathway and discuss the disorders in which it occurs, review the pathophysiology, the clinical features, and management of classic homocystinuria, as well as the same for the Cobalamin defects. And at the very end, we'll touch very briefly on MTHFR deficiency as well. So let's start with the biochemistry. I think that always gives groans, so I'm surprised I didn't hear any because I'd grown myself after all these years in biochemical genetics. So the homocystinuria are a group of inherited disorders in which the body can't properly process the amino acid homocysteine, and then it leads to the accumulation. And just recall that amino acids are both the building blocks as well as the breakdown products of protein. So it sort of all begins with methionine. Methionine is what we call an essential amino acid, which means you have to receive methionine from food. There's a variety of essential and non-essential amino acids. And methionine is converted in a multi-step process to homocysteine, and then homocysteine is then converted to cystathionine and cysteine. Cysteine itself is used for protein synthesis and, importantly, the production of glutathione. And glutathione is a very important antioxidant in the body. It kind of protects us from what we call the free radicals, so it protects the cells. And both methionine and homocysteine also play a role in things such as protein synthesis, protein folding, and protein function. So blocks in any part of this pathway often result in elevated homocysteine levels, which can be dangerous. So there are actually two important processes within the body that help clear homocysteine. This is where it gets more and more complicated, and you'll see the next slide. So transsulfuration is one of those processes, and this process helps regulate the sulfur-containing amino acids and reduces homocysteine by converting homocysteine to cystathionine and cysteine. And then you have what's called the remethylation pathway, which recycles homocysteine back up to methionine. There is also a third branch in this pathway, and this is called transmethylation, which we won't talk a lot today, but it transfers sort of what we call methyl groups from methionine to homocysteine, and along the way you lose these methyl groups, which are important in things like DNA, RNA synthesis, and other protein synthesis. So here's one of those complicated slides, and I don't have a great pointer, but can you see? You don't see it up there either. Okay, so we're gonna walk through this. So as I said earlier, it all starts with methionine. So there should have probably been a big, dinner plate up before methionine, and because again, as we said, you get most of your methionine from your food. So it starts with methionine. If you go to your right, you'll see the transmethylation pathway. That's the pathway that we're not going to talk a whole lot about. Those are the methyl donors that give what we call methyl groups to DNA, RNA, protein synthesis. But as you can see, methionine, if you look at the direction of the arrows, methionine goes through that pathway to get to homocysteine, and then homocysteine goes down to cystathionine and cysteine. And in the red box down there, the block of homocystinuria is cystathionine beta synthase. So that's one of the blocks that we'll talk about today. Then you'll see that the arrow from homocysteine back to methionine is an up arrow. and that's the remethylation pathway, where homocysteine is converted back to methionine and requires methionine synthase. A couple other things I'll point out on this slide is that cystathionine beta synthase has a cofactor or helper of B6, pyridoxine. Many of you might be on pyridoxine. And methionine synthase requires a cofactor or the helper of B12. And we'll talk a lot about the cobalamin defects, which are the B12 defects, later. I will also point out really briefly that on my left, your left, I guess, up there, the folate cycle is also really important. There can be inherited defects in the folate cycle, and the one that causes homocystinuria is the 5,10-methylene tetrahydrofolate reductase deficiency, or MTHFR, which we'll touch on very briefly, like I said at the end. But I want to point it out on this slide because this slide sort of pulls it all together. And I always sort of visualize this pathway as a big circle on the right, a big circle on the left, and then straight down. And it sort of keeps you going where you need to go. So let's start with classic homocystinuria. So this is a block in transsulfuration, homocysteine down to cystathionine. So these are kind of the many faces of individuals with homocystinuria. Some of these are very classic, and some of these are the ones we hope to see more and more nowadays with newborn screening. So classic homocystinuria was initially discovered in 1962. As you heard in Margie's talk, her siblings were diagnosed in 1964. So again, very early in the path of the journey for homocystinuria. There's a broad worldwide prevalence of homocystinuria. In Qatar, it's 1 in 1,800 individuals. That means that there's a founder defect, that almost everybody has the same pathogenic variant in their DNA. In other populations, like in East Asia, it's 1 in 4 million, so very rare in the Asian population. And the worldwide prevalence is felt to be about 1 in 250,000 to 350,000 or so. As mentioned, classic homocystinuria is a defect in the enzyme cystathionine beta synthase. You'll also hear CBS. And again, as we noted, you get an accumulation of total homocysteine and you get elevated methionine levels. We now diagnose, or hopefully diagnose, a lot of it on newborn screening. It depends on what your state is doing, but most of the time the marker on newborn screening is an elevated methionine. Now a lot of states have added a total homocysteine level as a secondary marker, which is good because that increases the sensitivity of the newborn screen. We still think we might be missing 30 to 50% of individuals with homocystinuria on newborn screening, mostly in the states where you'd have just testing with methionine, because not always is the methionine that elevated in that first 24 hours or 2 weeks of life. So if we're just using methionine, we know we are missing patients. And we also think we've missed quite a few individuals that have the B6 responsive homocystinuria as well. So involved organs, many of you guys know this information. So the 4 main organ systems involved are the eyes, the skeleton, the central nervous system, and then the vascular system. So from an eye standpoint, we see dislocated lenses, very frequently kind of downward dislocated lenses. From a clinical standpoint, that's just a little pearl in that there's another disorder where we see lenses dislocated, typically upward. You can have nearsightedness, glaucoma, retinal detachment, some optic atrophy, cataracts. Skeleton-wise, there's a whole kind of host of features that we can see. Individuals classically were kind of tall and lanky with long arms, long legs. We call this a marfanoid habitus. They might have scoliosis or curvature of the spine, some increased risk of fractures, osteoporosis, knock-kneed, high arches to their feet, etc. From a central nervous system standpoint, we used to see a fair degree of intellectual disability and developmental delays, seizures, and psychiatric illness. And then most probably importantly are the vascular features, as these lead to the most often the morbidity and mortality that we see with this disorder. And that would be the clotting disorders, the strokes, the DVTs, the pulmonary embolus, those sorts of things. Untreated homocystinuria, again, there's usually no symptoms in the newborn period. It's why we really want to identify it in the newborn period, because otherwise kids go for a while before they present with a clinical feature. And we do know that if we treat early, we think we do a better job with long-term outcome. So we would love to be making this diagnosis as early as possible. In untreated, I really want to emphasize some of this information is untreated homocystinuria. Approximately 60% of individuals had significant cognitive impairment by age 12. Seizures were common in about 20% by about age 12. And then, of course, you'd see the blood clots, the tall, thin stature, the dislocated lenses. And treated, we still see some of those complications, but we significantly reduce the risk of those complications. So we hope we do better with treatment and decrease the risk, particularly of the stroke events, the seizures, the intellectual disability, the dislocated lenses, et cetera. And of course, the B6 responsive individuals typically have a much milder phenotype. And if they respond fully to B6, they tend to do quite well with sort of limited medical involvement. These next three slides are what we call time to event graphs or time to event curves. This is very old data, so I really want to emphasize this. This came out in a publication by Dr. Mudd in 1985, and this was sort of pre-betaine era as well, so we don't have the information, but it was kind of one of the best natural history studies that was published at the time. So this initial time to event curve is for the thromboembolic events in untreated patients. And I want to point out that three graphs are kind of B6 responsive, B6 non-responsive, and the whole group entirely. And I put the circles kind of where I estimated the 50th percentile is, essentially. So in this situation, you can see that the risk for vascular events was about 25% by age 16 and about 50% by age 30. That's pretty young to have a stroke, if you will. If we think about kind of strokes, a lot of individuals have strokes at a much older age. And then there was also a risk for things like deep vein thromboses, pulmonary embolism, all kinds of other risk there. Similar, this is the time to event graph for dislocated lenses in, again, untreated patients. And you can see here that the 50th percentile is actually quite high. So 86% of patients at the time were ascertained because of dislocated lenses. And we still see that now. I follow a couple kids that just were diagnosed, again, by ophthalmology, by presenting with dislocated lenses, and about the same age group where we see that dislocated lenses occur in about half the patient population by age 6. That's about the time that these youngest ones are coming to clinic still. And that's in the B6 unresponsive group, and still about age 10 in the B6 responsive group. And finally, this is the time to event graph for spinal osteoporosis. And again, if you look where that 50th percent is, it's about age 16 or so, maybe 18. And if you think about significant osteoporosis, usually we see that in, my age group or older. Let's hope a little older. But 70s, 80s, older individuals. And this is in teenagers where we see this significant risk of osteoporosis. Hopefully we have changed those time to event curves. And unfortunately, there's not been really good long-term natural history studies until recently. Travere Therapeutics had prompted a natural history study. There's other smaller ones. And like I said, these were really historic and pre-betaine era. So hopefully all those curves have changed in the last 20 to 30 years. I would also say there's a caveat to the natural history here, in that if we look at genetic population-based screening, where we look at molecular changes that we know cause homocystinuria in a population, we see more genetic change than we do see individuals affected with homocystinuria. And when they looked at the clinical picture of those individuals, the presentation was a much later presentation and also just much more vascular disease and not all the other complications. So these time to event curves and the older information also suggest what we call a bias of ascertainment. Those patients that presented most involved with most clinical symptoms were what's reflected in those graphs, and that the milder end of the spectrum that maybe we didn't pick up clinically are not being reflective in those graphs. So from a very clinical standpoint, the diagnosis of homocystinuria, we talked about that nowadays, hopefully, it's via newborn screen. We look at methionine phenylalanine ratio as a secondary marker, and then also hopefully now total homocysteine as a secondary marker as well in most state screening programs. You will see if you do a set of amino acids, you see an elevated plasma methionine level and an elevated total homocysteine. And then ideally, you would also see the downhill effects of lower cystathionine and lower cysteine. We used to have to do enzyme assays on like skin or blood or liver samples. Now, for the most part, we do molecular testing or genetic testing to kind of clarify the pathogenic variants, to kind of confirm the diagnosis. And in homocystinuria, there's many, many different pathogenic variants. We don't just have one, isolated pathogenic variant, except, like I said, in a few populations. So pathophysiology, what causes the problems in homocystinuria? So we do think it's homocysteine as part of the problem, probably a big part of the problem. So you see homocysteine-induced generation of reactive oxygen species. These are those free radicals. These are things like hydrogen peroxide, superoxide. They're very dangerous to cells. They kill off cells, essentially. They're not healthy at all in that regards. And because we have the downhill effects of the decrease in cysteine, the main pathway that helps us get rid of oxygen-free radicals is your glutathione. And we have decreased amounts of glutathione. We also see disruption of other protective nitrogen pathways, which all total causes problems with proteins, fats, and DNA. We also see homocysteine-induced abnormalities in platelets, in the endothelial cells, which are the cells that are inside your vessels, your vessel cells, and in the coagulation factors. And this is causing probably the hypercoagulable state that we see and the altered stability of the blood vessels. So these features probably very much contribute to the kind of the clotting events, the thromboembolic events, and potentially the intellectual disability that we see. In addition, homocysteine also disrupts what we call collagen cross-linking. Collagen is one of your connective tissues, and it's a very complex cross-linked process. And when those are disrupted, your collagen's not very strong. So homocysteine disrupts that. We also see impaired methylation. Methylation is a process which sort of turns on and off other genes. And again, as we mentioned, decreased cystathionine and cysteine. All these are associated with things like cell death, cellular stress, inflammation, and alterations in other proteins, specifically fibrillin, which is important for your eyes, which may then account a little bit for the dislocated lenses, and also elastin, which is again part of your connective tissue. So these features in the pathophysiology probably contribute to things like the skeletal features and the eye dislocations, lens dislocations. What causes the problems in the central nervous system is a little bit, I would say, less clear and probably multifactorial. And I don't think we still have a really good understanding of it. Years ago, I asked Dr. Krause, who worked at our institution, what causes the intellectual disability that we see with homocystinuria? And even at that time, he's like, we really don't know for sure. I think we, of course, are learning more and more. But once again, we think that the total homocysteine level induces those oxygen-free radicals, even in brain tissue, again, causing problems with fats and proteins and DNA. You also probably have some contribution from the thromboembolic events. Perhaps there's some thromboembolic events occurring that might lead to some cognitive decline, or larger events that lead to neurologic deficits. And then homocysteine probably adds to brain cell excitability, which may then contribute to the seizures that we sometimes see with homocystinuria. So it's a complicated story and continues to be investigated. So from a management standpoint, the goal is to reduce or normalize plasma homocysteine levels. And specifically, we look at total homocysteine. And again, at the same time, optimizing nutrition, maintaining normal growth and development. So everybody that's newly diagnosed typically gets a trial of B6. They used to describe about 50% of individuals being responsive to B6. I'm not sure that that's necessarily what we see clinically, but occasionally we see individuals that are very responsive or at least partially responsive to B6. And often, even if you only have a partial response, you will continue to be treated with some B6 along the way. Methionine-restricted diet continues to be probably the cornerstone of treatment. That's the best way to limit the intake into that pathway. It's also probably one of the most difficult things we ask patients and families to do. It is not an easy diet. Betaine or cysteine, again, converts homocysteine back to methionine. Hence, it decreases homocysteine levels, but it does increase methionine levels. We feel, however, that high methionine levels, unless they're very significantly elevated, those don't tend to be problematic. But we watch methionine levels while we treat with betaine. We also will add some folic acid as a supplement, because as you kind of run that cycle, you need to add the folic acid, otherwise you'll deplete your folic acid and then the cycles don't run as well. So that's sort of an extra supplement that's provided. We used to supplement a fair amount of cysteine when I first started. You won't see that done quite as much, I don't think. At least I don't think we do it in our clinic anymore. And there was some interesting animal models that came out that showed that animals with homocystinuria that were given cysteine actually did more poorly than those that were not given cysteine. So for example, they didn't grow as well. And so now cysteine supplement isn't given as often as a supplement. That being said, the metabolic formulas, if you're on metabolic formula, typically is supplement with cysteine. So there is some cysteine provided. And then we talked a little bit about B6 and or B12 supplementation. As you recall, B12 is that cofactor for methionine synthase to move homocysteine back to methionine. And here it is just kind of in a graphic mode. So how we can intervene. Again, at top, we can use diet to decrease methionine levels. We can use betaine to move homocysteine back up to methionine. Again, for that pathway, you could provide some B12 or extra folate. On the bottom pathway for cystathionine beta synthase, you can provide B6. And then again, the question about cysteine, as we discussed. So the nice thing about biochemical genetics is that you can look at the pathway and like block here, this goes up, this goes down, intervene here. So other things that we look at for management include monitoring laboratory studies. We do amino acids, we do nutrition labs, we do total homocysteine levels. We watch for bone and eye disease, so we make sure patients have DEXA scans and see the ophthalmologist pretty routinely. We monitor development. We consider psychiatric screening if there's any indication. We might add things like aspirin or other antiplatelet aggregation medications, particularly if total homocysteine levels remain elevated. We could even consider anticoagulation therapy. Again, mostly if total homocysteine levels are very elevated. I would say we try hard to ensure hydration during times of activities, during times of surgery. We don't want kind of stasis. We don't want to increase that risk of clotting. Similarly, to avoid long periods of things like sitting or inactivity. If someone's on an airplane, maybe get up and walk up and down the aisle a little bit, but do things that get you and keep you moving. We try to avoid nitric oxide during surgical procedures. Nitric oxide itself increases total homocysteine levels, so may increase increased risk during surgeries. Avoid regional anesthetic techniques, again, because of just blood vessel stasis, blood stasis. For women, avoid the estrogen-containing contraceptives because that has also an additional risk factor for clotting. And then I think it's important for our patients to discuss when we say you're at risk for a DVT, you're at risk for pulmonary embolism, what sort of symptoms to look out for. So particularly for my teenagers and adults, we talk about what do you look for if you think you might be having symptoms of a stroke or pulmonary embolism or DVT. And on the horizon, we do potentially have an enzyme replacement therapy. I think that's very exciting. The Travere Therapeutics team is here today, but you'll have other presentations about this as well. So outcome prognosis is largely associated with the degree of vascular involvement. Thromboembolism, as we say, is the most common cause of death. Historically, it was in about 25% of patients before age 30. I don't think we see that anymore, but we certainly know that lowering total homocysteine levels significantly reduces that risk. And we think betaine therapy has also helped improve the outcomes of individuals. Overall, newborn screening has also improved outcomes. But we recognize it continues to have a large burden of therapeutic care for individuals with homocystinuria. All right, we gotta speed this up. So as a reminder, all homocystinuria is not cystathionine beta synthase deficiency. The other group of disorders that I know are represented here today are what we call the Cobalamin defects or the defects in B12. This is a whole group of also genetic conditions that affect the absorption, transport, intracellular metabolism of B12, and it impairs two key enzymes, methylmalonyl-CoA mutase, which requires adenosylcobalamin, and methionine synthase that requires methylcobalamin. And these disorders are characterized both by elevations of methylmalonic acidemia or homocystinuria, or both. So we'll try to mostly talk about those that are related to homocystinuria today. But they're divided into three categories: absorption and transport, intracellular metabolism, and now there's some newer ones that are affecting what we call transcription factors that regulate some gene expression. Those are very rare and kind of newly described. So this is kind of a complicated slide, but this is your absorption and transport of B12 from the time you take it in your diet, which mostly comes from things like red meat, until it gets into the cells. So it's released from the food in the stomach, and it's bound to a product called haptocortin. Then that is all transferred into the upper intestine, and the B12 is transferred to what's called intrinsic factor. And then that, once it's in the lower intestine, is eventually transported into the cells, where then the next set of disorders comes into play. So these disorders are kind of, I would say, very rare. I've rarely seen them in my kind of 30 some odd years of seeing kids with metabolic disorders. They're very variable in presentations. They present early in life. They can have a variety of symptoms, particularly anemia, growth faltering, some GI symptoms, or can be completely asymptomatic. In this case, you typically have elevated methylmalonic and homocysteine, and most of these conditions will have low B12, which will be a key because some of our other conditions, you have normal B12 levels. But when you can't absorb appropriately B12 from your diet, then you have low B12 levels. And they respond well to often oral therapy with B12, which, as those of you know with remethylation defects, we don't usually use oral therapy. But these are listed here, and like I said, they're pretty rare. I'm going to skip this slide, except for to say this is to visualize where we are with the pathway. So we've talked about the top bright pathway. We talked a little bit about the folate pathway. And then this pathway intersects everything as it goes forward, but it's sort of a separate pathway. So these are the remethylation defects when we talk about defects of intracellular utilization, how the cells utilize B12, how the cells process B12. So as I mentioned, you can have methylmalonic and homocystinuria. These are the ones listed. You can have homocystinuria only because it only affects methylcobalamin. And you can have methylmalonic only because the defects only affect adenylcobalamin. So we won't talk about the last category, but we'll touch on the other ones. Again, a very complicated slide, but what it's trying to tell you is that on the far left, that's the absorption site. You can see the cobalamin transport and metabolism, dietary intake. And then once you get into the enterocyte and the bottom pathway, you can see that there's a shared pathway, and then it branches, and part of the pathway goes north to adenylcobalamin up there for methylmalonyl-CoA mutase, and part of the pathway goes south to methylcobalamin, MET-CBL, and to methionine synthase. So when you have a shared pathway, that's when you get both methylmalonic and homocystinuria because it's before the bifurcation. Then when you have just a defect on the top half, those folks only have methylmalonic acidemia. And when you have defects on the bottom half, those folks have homocystinuria. So, and all the little green boxes are the described conditions. And as you can see, they're described as cobalamin A, B, C, D, E, etc. And sometimes new ones get described all the time. I had to add K to the slides this time. So there's a lot of common features, and you'll see there's big categories here. Most of the time there's hematologic features. We talk about megablastic anemia, which means that when you have a defect in B12, a lot of times you have low red cell counts, but the cells are big, and that's kind of unique to B12 deficient conditions. You can also have all your cell lines low, that's pancytopenia. You can have neurologic features. You can have some really interesting renal features. Hemolytic uremic syndrome is a very interesting condition, largely associated with cobalamin C, or we can see it isolated in kids without metabolic disorders, but it's kind of unique for cobalamin C defects. You can have the eye features, again, commonly in cobalamin C, and they also have the vascular features. Very variable clinical presentation, very variable age of onset, anywhere from infancy to adulthood. Again, sometimes we can make these diagnoses by newborn screening. Particularly, you'd have to be screening for total homocysteine to pick up the homocystines. But methylmalonic, the marker then on newborn screening is called C3. And we pick that up pretty easily on C3. So any baby that flags for an elevated C3 automatically gets a homocysteine level as follow-up. So that nowadays we're picking more and more of these conditions up on newborn screening and hopefully starting therapy early and getting much improved outcomes. Again, you'll see elevated homocysteine and methylmalonic levels. The methionines are typically low or low normal, which is different than classic homocystinuria. If you recall, classic homocystinuria has the elevated methionine levels. In these situations, again, B12 is often normal, and we really do have to do the genetic testing nowadays to confirm. Goal of therapy is kind of the same as homocystinuria, classic homocystinuria. In this situation, though, we tend to use high-dose hydroxycobalamin, so a high-dose B12, IM or sub-Q, hydroxo, better than cyano. We use oral betaine. We use a variant of folic acid called folinic acid, sometimes carnitine. A lot of subspecialty care, similar to individuals with classic homocystinuria. And of course, developmental and academic supports as well. So I'm going to briefly call out cobalamin C disorder as being the most common of the remethylation defects. Again, this is a combined defect with methylmalonic and homocystinuria. And the gene is listed, MMACHC. They're all kind of funny names. It's alphabet soup these days for gene names. And as I kind of already mentioned, a variable presentation, anywhere from infancy to adulthood. and a lot of variable clinical features as well as variable neurologic features. This is a list of the other combined defects. I will point out that I put sort of the numbers of patients that have been described. So Cobalamin C, we have lots of patients. For these other disorders, certain numbers are still listed in the literature. And like I said, that Cobalamin K I just added, one patient at this point has been described. Now that's what's described in the literature. There's likely more patients out there. But the clinical presentations, all very similar. These are just a couple pictures of some patients that I had over the years. These were the first two brothers described with Cobalamin D. They were diagnosed at the University of Colorado before my time. And then real quick, homocystinuria only disorders. These are the methylcobalamin deficiencies. This is cobalamin E and cobalamin G. You can see that E is a deficiency of methionine synthase reductase, and G is a deficiency of methionine synthase. Kind of the same sort of clinical features though. Very variable, multi-system, and again, elevated homocysteine, this time normal methylmalonic, and normal or low methionine. And these individuals get treated about the same way from the standpoint of hydroxycobalamin, betaine, methionine supplementation, if the methionines are low, etc. And last but not least, I will very briefly mention methylene tetrahydrofolate reductase deficiency, better known as MTHFR. This is a defect in folate-dependent methylation pathway. So it's on the far right. It was in the folate recycling pathway. And this can be a very severe deficiency, particularly from the standpoint of brain development. But I do want to point out that this is the one, when we talk about this deficiency, it is autosomal recessive, 2 variants in this gene, and it is not to be confused with what we call the common polymorphisms that are potential risk factors for clotting that sometimes people get tested for from the standpoint of their primary care testing for these 2 variants that are listed here. Those are what we call the common thermal label polymorphisms. They do not cause the severe methylene tetrahydrofolate reductase deficiency. And as I said, this can be quite a severe condition when it's found, but it's pretty rare. So that is it, and I think I made my time limit after we sped up a little bit. So.